Hi and welcome to this audiobook on the topic intraabdominal infections. We will begin with the framework of the IDSA intraabdominal infections, abbreviated as IAI guidelines. The initial treatment consists of fluid resuscitation, initiation of antibiotics, source control, and microbiologic samples. Antibiotic selection is based on type of infection, which could be 1. Community-acquired infection of mild to moderate severity. 2. Community-acquired infection of high severity. 3. Healthcare-associated infections with a focus on A. Candida, or B. Enterococcus, and C. MRSA. Defining types of intra-abdominal infections. A. Community-acquired infection of mild-moderate severity applies to cases of patient coming in from the community without risk for treatment failure. B. Among those with community-acquired infection of high severity, we have characteristics of high-risk patients such as patient-specific factors like advanced age, that is, above 70 years of age. Immunosuppression, presence of malignancy, pre-existing chronic conditions. We also have disease-specific factors, like high Apache score that is above 15, health-care-associated infections, delay in initial intervention that is longer than 24 hours, and inability to obtain source control. Next we will look at healthcare-associated infection, which is considered high severity with a focus on MDROs. Let's now look at specific definitions. A. Community-acquired refers to cases that are not healthcare-associated, see definitions below. B. Healthcare-associated. This category has the presence of any risk factor like invasive device at time of admission. History of MRSA infection or colonization. History of surgery, hospitalization, dialysis, or residence in a long-term care facility in the past 12 months. C. Hospital onset. Here we have positive cultures more than 48 hours after hospital admission. Let's look at a few more definitions. A. Uncomplicated IAI. Here the infection affects a single organ only without spread into the peritoneum. B. Complicated IAI. Here there is an infection extension beyond hollow viscus of origin into peritoneal space, with peritonitis or abscess formation. We will now consider IAI-specific pathophysiology. The number of organisms present increases as you move distally through the GI tract. For example, the stomach has very few organisms, and the colon has billions of organisms. Pause the video and scrutinize the table summarizing microbiota in the GI tract. We will now continue looking at IAI-specific pathophysiology with a closer look at the different organs. An infection of the appendix is called appendicitis. That of the gallbladder is called cholecystitis. That of the bile duct is called cholangitis. That of the pancreas is pancreatitis, and that of the colon is called diverticulitis. It is important to differentiate between cholecystitis and cholangitis. Let's transition to the treatment of high-risk, community-acquired or complicated appendicitis. It is a high-risk infection which needs broad-spectrum and anaerobic coverage. And now, pause the video and scrutinize the table summarizing antibiotic recommendations for treatment of appendicitis. We will now briefly look at patient management. Blood or fluid cultures are not routinely needed for patients with community-acquired infection unless they appear clinically toxic or have a high risk for MDRO infections. Let's briefly discuss the STOP-IT trial. It was a high-impact study that assessed appropriate duration of antimicrobial therapy with appropriate source control. Pause the video and scrutinize these tables which summarize the STOP-IT trial design and duration of therapy. Duration of therapy. The STOP-IT trial, there was no significant difference in study endpoints regardless of duration of therapy, indicating that shorter duration of therapy did not affect response rates with a p-value equal to 0.92. The post-hoc analyses. Polymicrobial infections do not have worse outcomes than monomicrobial infections. Patients with complicated IAI presenting with sepsis do not require a duration of antibiotic therapy longer than 4 days. Inclusion of vancomycin as part of broad-spectrum coverage does not improve clinical outcomes in IAI. The bottom line is, complicated IAI can be treated with 4 days of antibiotics if adequate source control provided. And now, let's look at additional data to support shorter durations of antibiotic therapy. The STOP-IT trial results are also supported by 2 other studies on post-laparoscopic appendectomy for acute complicated appendicitis. One was a multi-center cohort study, which involved a shorter duration of post-op antibiotics. That is 3 days versus 5 days. It was associated with a similar risk for infectious complications. The second was an RCT of post-cholecystectomy for acute cholecystitis. It only represents the findings of one study. The use of no antibiotics was non-inferior to 5 days of amoxicillin clavulanic acid for preventing postoperative infectious complications. Let's now briefly discuss the management of appendicitis with antibiotics only. It is a current controversy. Can appendicitis be treated with antibiotics only and not surgery? The answer is no, and the rationale is that 2 recent non-inferiority studies demonstrated that antibiotics alone are inferior to surgery plus antibiotics for acute appendicitis. Let's now briefly discuss healthcare-associated intra-abdominal infection. By briefly looking at the SIS and IDSA approved empirical antimicrobial therapy for healthcare-associated complicated IAI. These guidelines recommend we initiate treatment with empirical therapy adjusted for the antibiogram of your institution. If there are ESBL-producing Enterobacteriaceae in your hospital, or if there is a high level of Pseudomonas resistance to ceftazidime or cefepime, it is recommended to add an aminoglycoside. Pause the video and scrutinize the table summarizing empirical antimicrobial therapy for healthcare-associated complicated IAI. Let's now consider other pathogens. Enterococcus. Antimicrobial therapy is recommended when Enterococcus is grown from patients with healthcare-associated intra-abdominal infections. Empirical anti-enterococcal therapy is recommended for patients with postoperative infection, previous use of cephalosporin, or other Enterococcus-selecting antibiotics, or valvular heart disease. We should target Enterococcus faecalis in empirical therapy. We should target Enterococcus faecium in liver transplant or known colonization with vancomycin-resistant enterococci, abbreviated as VRE. Let's now look at other pathogens. We will begin with Candida. If Candida is grown from intra-abdominal cultures, initiation of antifungal therapy is recommended. Fluconazole is recommended if Candida albicans is isolated and the patient has had no prior use of fluconazole. Echinocandine use is recommended in patients who are severely ill, recent use of fluconazole, or isolation of fluconazole-resistant species, e.g., Candida glabrata. Other pathogens include MRSA. Empirical therapy directed toward MRSA. Usually, vancomycin is recommended to patients with healthcare-associated infection who are colonized or at risk because of previous treatment failure or significant antibiotic exposure. And now let's look at new antibiotics for IAI. They include ceftolozane tazobactam and ceftazidime avibactam. These novel antibiotics have no activity against Enterococcus. They have no activity against anaerobes. KPC. Ceftolozane tazobactam is not active against CREs with KPC beta-lactamase. That is the most common CRE in the USA. Both of these medications are FDA approved for IAIs. Pause the video and scrutinize the table summarizing new antibiotics for IAI. Pause the video and scrutinize the table summarizing clinical trials related to IAI. We will now consider pancreatitis and spontaneous bacterial peritonitis by looking at a summary of recommendations for acute pancreatitis and the 2013 American College of Gastroenterology (ACG) guidelines. A life-saving event in pancreatitis care is aggressive hydration by administering 250 to 500 ml per hour, especially in the first 12 to 24 hours. Lactated ringers is the preferred IV fluid. Routine use of prophylactic antibiotics is not recommended. It's not recommended for sterile necrotizing pancreatitis. Antibiotics are recommended if extrapancreatic infection is present, e.g. in the case of cholangitis or bloodstream infection. In patients with infected necrosis diagnosed via CT scan or similar radiology, antibiotics known to penetrate the pancreas may be used. These include carbapenems, quinolones, and metronidazole. It is difficult to distinguish between sterile necrotizing and infected necrosis on CT. We will now consider spontaneous bacterial peritonitis, abbreviated as SBP. Let's begin with diagnosis and management. Diagnosis. It is diagnosed in case of a positive as-cytic fluid bacterial culture and an elevated as-cytic fluid absolute PMN count of above 250 cells per millimeter cubed without an evident intraabdominal, surgically treated source of infection. When to start empirical antibiotics. This is done when there is a polymorphonuclear leukocyte abbreviated as PMN count of equal to or more than 250 cells per millimeter cubed. Organisms. 1. Community-acquired SBP. This requires gram-negative coverage. 2. Healthcare-acquired SBP. This requires expanded coverage to MDROs and gram-positive organisms. Let's briefly look at treatment of spontaneous bacterial peritonitis. With an emphasis on the American Association for the Study of Liver Diseases abbreviated as AASLD guidelines, initial treatment recommendations is based on severity. The duration of therapy is 5 days. Pause the video and scrutinize the table summarizing treatment recommendations for spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. Secondary prophylaxis. There is no need for follow-up peritoneal studies if the patient is clinically improving. Secondary prophylaxis. Patients who survive an episode of spontaneous bacterial peritonitis should receive long-term prophylaxis with daily norfloxacin or trimethoprim sulfamethoxazole. Levofloxacin would also be appropriate, although it is not mentioned in the guidelines. IAI. Acute cholangitis. Definition. It is a biliary obstruction complicated by infection. Its presentation can be severe, with jaundice and elevated transaminases. There are high mortality rates of 11 to 27%. It is important to start early broad-spectrum antibiotics. Source control. It is usually via endoscopic retrograde cholangiopancreatography directed internal drainage within 24 hours. Empirical therapy. It involves broad-spectrum antibiotic therapy with gram-positive and negative coverage including anaerobes. Enterococcus coverage is indicated in patients with hepatic disease or severely immunocompromised patients. Let's now look at diverticulitis. Definitions. It is the inflammation and microperforation of a diverticula containing segment of the colon. It involves a diverse variety of gut microbes. It is important to start broad-spectrum antibiotic therapy early. Source control. This is controversial, aggressive medical support and non-urgent surgical that is via laparoscopic drainage. Most patients do not require surgery, e.g., those with abscesses less than 3 cm resolve with antibiotic therapy alone. Empirical therapy. Antibiotic coverage with both gram-negative and anaerobes for 4 to 10 days is recommended. Exact day of stopping antibiotics is controversial. Research is needed to determine whether fewer days of therapy will suffice. Gastrointestinal infections overview. Infectious diseases of the gastrointestinal tract involves 3 main disease states. Namely 1. Helicobacter pylori infection, 2. Infectious diarrhea, and 3. Clostridioides difficile infection. Let's consider a few relevant guidelines. They include 1. ACG Helicobacter pylori 2017 Guidelines. 2. IDSA Infectious Diarrhea 2017 Guidelines. And 3. IDSA Society for Healthcare Epidemiology of America Clostridioides difficile 2018 Guidelines. Helicobacter pylori. Helicobacter pylori infection is usually acquired in childhood. There are higher incidence among adults born outside of North America, especially within the developing world. It varies with socioeconomic status and race or ethnicity. All patients tested positive for Helicobacter pylori should be treated. There is an increased risk for gastric cancer if it is left untreated. All patients with peptic ulcer disease should be tested for Helicobacter pylori. Also consider testing in patients taking low-dose aspirin or chronic nonsteroidal anti-inflammatory therapy to reduce the risk of GI bleed. If a patient has Helicobacter pylori and takes one of the medications, they are at an increased risk for a bleed. Approved first-line therapies for Helicobacter pylori infection. FDA-approved therapies include proton pump inhibitor abbreviated as PPI plus clarithromycin plus amoxicillin or metronidazole for penicillin-allergic patients for a total duration of 14 days. Use of clarithromycin as part of triple therapy is only recommended if regional resistance to it is less than 15% or there is no prior clarithromycin exposure. An example of an effective but not FDA-approved therapy is a PPI plus bismuth subcitrate or subsalicylate plus tetracycline plus metronidazole for a total of 10 to 14 days. Use it especially if there is significant prior macrolide exposure. There are lots of other variations, including quinolone combinations. Let's now discuss the treatment of persistent Helicobacter pylori infection. It is recommended for patients who previously received clarithromycin as part of triple therapy. It involves the use of a bismuth-based quadruple therapy. For patient who previously received bismuth-based quadruple therapy with no quinolone allergy, use levofloxacin triple that is with a PPI plus amoxicillin. For those with quinolone allergy, use rifabutin plus PPI plus amoxicillin. We will now look at infectious diarrhea. It is a very common condition. The World Health Organization (WHO) estimates that approximately 2 million cases occur per year. It is the leading cause of death worldwide in children below the age of 5 years and the third leading cause of death in low-income countries. In the developed world, it's often not thought of as more than traveler's diarrhea. Let's now look at its risk factors. They include travel to developing countries, close contact with infected persons, and poor sanitation. Infectious diarrhea guidelines address a huge diversity of etiologies and potential pathogens. Most importantly, know when to treat with antibiotics, refer to slide deck. Fecal leukocyte and stool lactoferrin detection should not be used to establish the cause of acute infectious diarrhea. And now let's look at the etiology of infectious diarrhea. It may be foodborne or waterborne. It can also be caused by international travel. The use of antimicrobial agents. It may be due to an immunocompromised state of the host. It can also be due to exposure to infected or colonized animals, also referred to as zoonotic infections, or due to attendance at child care facilities. It can also be due to residence in long-term care facilities. Due to hospitalization. This usually applies to Clostridioides difficile. And finally, due to certain sexual practices. Please see Table 2 in IDSA guidelines for pathogens associated with each etiology. It is recommended that you know the top causes of each type of infection. We will now briefly talk about the treatment of infectious diarrhea. Oral zinc supplements reduce the duration of diarrhea in children 6 months to 5 years of age who reside in countries with a high prevalence of zinc deficiency or malnutrition. Pause the video and scrutinize the table summarizing the approved antibacterial therapy for infectious diarrhea by pathogen. Pause the video and scrutinize the table summarizing the approved antiparasitic therapy by pathogen. Pause the video and scrutinize the table summarizing the infectious diarrhea specific dosing. Pause the video and scrutinize the table summarizing the infectious diarrhea with emphasis to very specific dosing. Let's briefly discuss Clostridioides difficile infection, abbreviated as CDI. We will begin with laboratory test recommendations based on pre-agreed upon institutional criteria. GDH is a common antigen of Clostridioides difficile that can detect either the toxigenic or non-toxigenic form. A positive test indicates the presence of Clostridioides difficile and should be followed by the PCR test. That is for stool toxin. Nucleic acid amplification test, abbreviated as NAAT. There is a concern that the PCR test is picking up colonization and not true infection. It is important to do a GDH, that is a glutamate dehydrogenase test, and add on the stool EIA, which is the enzyme immunoassay toxin test. Do not perform repeat testing within 7 days during the same episode of diarrhea, including do not order a test of cure. Do not screen for asymptomatic Clostridioides difficile carriage at admission. Let's now look at the treatment of CDI in adults. Regardless of severity, vancomycin or fidaxomicin are used for initial treatment. Metronidazole has been deemed second-line therapy. You can add it to vancomycin in cases of fulminant infection because this is currently the best option. The recommendation to limit the use of metronidazole for treating CDI was based on pivotal Phase 3 RCTs of tolivama, in which metronidazole was shown to be globally inferior to vancomycin. There are no recommendation on probiotic or PPI use. We should discontinue inciting antibiotic if possible. There is no evidence to support longer than recommended duration of Clostridioides difficile antibiotic therapy if a patient is on other concomitant antibiotics or restarting Clostridioides difficile antibiotic with start of other systemic antibiotic. Pause the video and scrutinize the table summarizing the initial treatment of CDI. Fidaxomicin. Vancomycin use is associated with significantly lower 30-day mortality than metronidazole, with a risk reduction abbreviated as RR equal to 0.86. With a 95% confidence interval of 0.74 to 0.98. There is no significant difference in CDI recurrence regardless of disease severity or choice of antibiotic, that is 16.3 to 22.8% of cases. Tolivama binds the toxins of Clostridioides difficile. Metronidazole was shown to be globally inferior to vancomycin. Pause the video and scrutinize the table summarizing the comparison of tolivama versus metronidazole versus vancomycin for treatment of CDI. Pause the video and scrutinize the table summarizing the higher failure rate of metronidazole versus vancomycin associated with increased 30-day mortality in patients with CDI. Monoclonal antibody directed against Clostridioides difficile toxin B, that is, bezlotoxumab but not toxin A, that is actoxumab, which was shown to decrease CDI recurrence. Toxin A and toxin B are two of the major Clostridioides difficile antibodies. The graph in the slide below is from a phase 3 trial. This monoclonal antibody was infused after standard therapy. Standard therapy was either vancomycin or metronidazole. Summary: bezlotoxumab was effective therapy for treating Clostridioides difficile. Pause the video and scrutinize the table summarizing the fact that monoclonal antibody directed against Clostridioides difficile toxin B, that is bezlotoxumab, but not toxin A, that is actoxumab, was shown to decrease CDI recurrence. Pause the video and scrutinize the table summarizing the MODIFY-2 trial results. Pause the video and scrutinize the table summarizing the treatment recommendations for recurrent CDI. Pause the video and scrutinize the table summarizing the results of a randomized, double-blind, placebo-controlled pilot study of the effect of rifaximin to prevent recurrent diarrhea in 68 patients with CDI. Pause the video and scrutinize the table summarizing the trial on duodenal infusion of donor feces for recurrent CDI. We will now look at potential other testable questions from CDI guidelines. Do not perform repeat testing within 7 days during the same episode of diarrhea, including do not order a test of cure. Do not screen for asymptomatic Clostridioides difficile carriage at admission. There is no recommendation on probiotic or PPI use. Discontinue inciting antibiotic if possible. There is no evidence to support longer than recommended duration of Clostridioides difficile antibiotic therapy if a patient is on other concomitant antibiotics or restarting Clostridioides difficile antibiotic with start of other systemic antibiotic. And now, in conclusion, treatment of IAI and GI infections depends on the etiology, severity, risk factors, anatomical location, and lab test results. Past exposure to antibiotics, the pathogen, and evidence-based guidelines should be taken into consideration in choosing anti-infective drug therapy for IAI and GI infections. Infectious disease pharmacists play an important role in managing the treatment of IAI and GI infection. Thank you.